Got a hernia, and a hernia in general should be repaired because it can precipitate an emergency. And timing for it, hopefully you'll be able to figure out and fit in with your life. I've been doing hernia operations as an emergency for 25 years, and the ability to predict when a hernia is going to become an emergency is really difficult. So understanding what a hernia is, how it affects you, and how you're going to get over the operation all tie in with work and life and expectations and fears and things. So hopefully a little information here is going to go a long ways and help you to understand what the next best step is for your situation. Because not everybody needs to have their hernia repaired right away. So what is a hernia? A hernia is a hole that allows something to go through it that's not supposed to be there. With abdominal hernias, generally what is there is a hole in the muscles, generally at a space where a blood vessel has gone through or is, and then the intestines begin to poke out through that hole. If it's a real small hole, it tends to pinch. As it gets bigger, it pinches less, and more comes through. As the hole gets bigger, more goes through. And the more that's through, the bigger it is, the faster it's going to get bigger. That is, a big hernia generally is getting bigger faster than a very small hernia, just by the bubble expansion process. When you have a hernia, you have a situation similar to having a gopher hole in your horse pasture. The gopher's happy, the horse is happy, but at some point, the horse might step in the gopher hole and break its leg and end its life. And that's the problem with having your guts come out through a hole. If you've got a ring that fits pretty smoothly, you're okay. It'll come in and out, in and out, in and out. If it's a little tighter in what's coming through, it won't come off. And if your guts get stuck in something that won't come off, then you've got a problem where you may have a bowel obstruction, where you precipitate an emergency, or the intestines that are stuck in there may get strangled. It's called a strangulated hernia, and the intestines die within 4 hours. And that precipitates an emergency where we've got to take out dead intestines, and the operation that could have been done electively with minimal impact on your life now becomes a life-threatening, middle of the night, who knows who your surgeon is, but you've got guts coming out and maybe even a colostomy where you're pooping into a bag. So intervening with a hernia in a timely fashion can be very helpful. Most hernias in the abdominal area are associated with where blood vessels come through. In men, the blood vessels to the testicle come through down there and leave a weak area. Those blood vessels leave that weak area and the guts pop out. That's an inguinal hernia. At the belly button, we all had an umbilical cord. That umbilical cord scarred down and stayed firm, but with pregnancy for women and pot-bellied men, that area gets stretched out, and now the guts can come out through the hole there where the old blood vessel used to come through. So those are common areas for hernias to occur. If you've had a prior surgery in your belly and they did a laparoscopy and stabbed you a few times, or you had a hysterectomy and or C-section or something, any place where the muscles have previously been cut also is an area where hernias can occur, and we call those incisional hernias. And incisional hernias are generally associated with internal scarring and are a little more difficult to repair, and sometimes can be quite large the first time that they show up because things didn't heal correctly. So in the end, when you have a hernia, you need to think about the timeline to get it fixed. And need to know that it will get bigger with time, and exercise is not going to make that better. And the most common reason that people choose to get their hernia repaired, though, is because they're having more and more pain. Patients who don't have pain in their hernias will let their hernias get huge many times before they get around to getting them fixed. But if you have a small hernia and it's causing a lot of pain, that's going to motivate you. And the pain is a warning that something is being pinched and something is being damaged and something could get worse. When it comes to hernias in the groin, if you've noticed a bulge and you're not having pain, There's a 1% chance per year of going on for strangulation in an emergency. But there's a 10% chance per year that you're going to develop enough discomfort that you can't golf, you can't work, you can't hike, you can't work on your car without it bothering you all the time. And you're going to ask, can I get this fixed? And they've done those studies, and it's pretty consistent. 10% per year end up with a lot of pain. So having a hernia doesn't mean you have to get it fixed now, but it does mean you're running some risk of emergency, and you're probably going to end up with it needing to be repaired with time. There are exceptions to that rule. The people that go decades, statistically speaking, 10% per year are going to be asking to have it repaired. After it's repaired, there's a time of recovery, and that time of recovery involves letting things heal together. For most hernia repairs, the standard of care is to put mesh in to make you stronger than before, so that that weak area doesn't continue being weak. Otherwise, you've got basically termite-infested wood that's being rebuilt into itself, and the failure rate's about 25% if you repair without mesh. In the groin, the failure rate's only 2% if you use mesh versus 25%. At the belly button, the failure rate's 5% with mesh versus 25% without mesh. So the mesh makes a big difference in whether or not you're back for a second hernia repair later on in life. Once the repair is done, your recovery generally is like you're up and around the house the night of surgery, up and around the yard the next day. Within a week, a stair climber, exercise bike, treadmill, walking a track, walking a little dog. If it's all legs and lungs, not challenging your balance or not requiring core strength, you're going to get along fine with the operation, and you'll be able to stay active and get your heart rate up and stay, in reasonably good shape, maybe even work on losing weight if you're taking on new exercises. But you're going to keep your core out of it. You're going to not be bending at the waist. You're not going to be twisting the trunk. If you're working in the shop and you're doing little things because you're not lifting heavy stuff, but you're working here and you're working here and you're working here, that twisting motion is taking that hernia repair and moving it around. If you had a broken leg, they'd put you in a cast. We can't put you in a cast very well, but in terms of healing from an abdominal hernia, you want to pretend that your shoulders and your pelvis are joined with a cast. If you need to work over here, get your feet over there and work there. Keep your elbows in so you're not extending and twisting overhead. Christmas lights are out. So get your feet here, work here in your kitchen, you get back over here. Use your feet to get where you need to be. Keep your shoulders over your feet and stay balanced. Body dynamics are real important in the hernia repair, and you want to keep your core lined up all the time. And part of that is getting in and out of bed in a way that makes good sense. So I don't want you getting in and out of bed doing sit-ups and straining your abdominal muscles. I don't want you getting in and out of bed doing log rolls. People land on the floor that way, getting out. But getting in and out, you're twisting the operation, you're using your abdominal muscles the way you never use it, and that's not a good way. So when you're getting in and out of bed after the hernia repair, first 2 or 3 weeks, I want you, and particularly if you've got a back problem, I want you to do it like you did when you were 3 years old. Instead of doing what you do now, you get to the end of your bed, you put your hands down, and you crawl in like a dog, like you did when you were 3 years old. You're a lot bigger now, so be crawling all the way, get your head up to the top of your bed, get some pillows ready before you do this, and roll over on a pile of pillows and get comfortable, whatever position works for you. Now at 3 o'clock in the morning, you gotta pee. You gotta get out of bed again. So no log rolls, no sit-ups. You wanna get on your belly, and then get your arms and legs under you up to a crawling position and crawl backwards out of bed. So this is you getting out of bed right here. Your hands are supporting your trunk, your knees are bent, you come up with your knees, you're straight, you're squared up, you haven't strained your back, you haven't strained your abdominal muscles, and you're ready to go. If you're a little woozy on the pain pills, right there to catch yourself, okay? But if you do that, you'll be in and out of bed with less pain, less worry, and certainly less strain on your repair. And if you've got a back problem in the first place, you'll minimize the strain, additional strain on your back from having an abdominal surgery. With any operation in the abdomen, particularly with hernia repairs, your balance is off for about a month. Say you had a hernia repaired on the left side here, and you're walking on ice outside. Well, these muscles are firing and the nerves are firing at normal speed. Your spinal muscles are firing at normal speed, but this is firing slower. So in the process of dealing with any kind of unpredictability, this is going slower, and that means your shoulders are being pulled in the wrong direction, and you get off balance very quickly, and falls are common after any abdominal surgery. And hernia repairs are a big part of that. So no roofs, no ladders, no motorcycles, no walking on ice. Anything that challenges your balance is best avoided for about a month after surgery. The other thing to avoid after surgery is lifting. The core muscles here have been operated on. We've got things that are trying to heal together. We've got mesh that's trying to get incorporated there. A fall is like an earthquake in a construction zone. It makes it so that it doesn't set right. It increases the likelihood of failure of the operation. Similarly, if you're exerting those muscles and making them pull against the healing process, you can end up with an early recurrence on your hernia as well. So this is the way to think about the healing process. It's like concrete. It's got a set. But it's more like a construction project. When you get an incision anywhere and you have to heal something, for the first month, you don't really heal anything but the skin. The rest of it down deep, you've got a building permit. And biologically, the site's being cleared and prepped. And the forms for the concrete are being dug into the ground, and the forms are being put in, the concrete's being laid, and lumber is being delivered to the site. But you don't see a house, you don't have anything that's strong, there's nothing there that's really healing internally in terms of strength for about a month. After that first month though, just like building a house, you get to a point where the framing goes up, and suddenly there's structure there, and suddenly there's some strength. And that's what happens in the second month after the healing process. This is why we have a 15-pound lifting restrictions for the first 4 weeks. That's 2 gallons of milk. That's not a lot. But it's functional, and you can get around with most stuff, but you're not going to want to strain that abdominal cavity until you've got that framing in position. And then over the next month, at the building site, you'll see the siding go on, the roof go up. Every layer that's going in is making it stronger and stronger, and that's what's going on biologically with your healing process as well. So at the end of 2 months, 80% of the healing is there, and just like finishing out a house, it's not done for a long time after the frame's up. It takes a year to get to 100% of the eventual healing strength. It's just that with your mesh involved in that healing process, you've now put rebar in the concrete, and that concrete's stronger than it would have been in the first place. So when you're at 80% of the healing strength, you're at a higher strength than there was initially with your initial tissues there. So that's why at 6 weeks we can say most people can begin doing heavy lifting, and we have a 50-pound lifting restriction that ends at 6 weeks. At that point, it's important to start stretching and toning, as much for your abdominal muscles as it is for your back. If you've got back trouble, an operation on the belly makes your back worse, because everything they teach you about back care is to strengthen your core and keep your core strong so that your belly, your spine is acting with a barrel around it rather than just a spine. So it's really extra important for anybody who's got chronic back pain or back problems, disc, sciatica, to really be careful about their posture, about their lifting, getting their feet in the right place, and not making their back worse in the process of getting over their abdominal operation as well. Once it's to the point of stretching, that's going from side to side, leaning back, leaning forward, getting all those muscles limbered up, getting your spine limbered up. If you go to a construction site in the morning, those guys in the orange vests are out there, they're doing these exercises for their back, they're doing it for their belly. They're limbering up those muscles, and that's what needs to happen here too. That mesh is between two layers of muscles. One pulls this way, the other pulls that way, and it's fused them together, and now they're going to be working, but they're tethered a little bit at one end, and those need to learn to stretch out and to move around so you don't end up with severe pains because you haven't stretched and you want to go pull an engine 4 months later, and now you pull something down there. Probably haven't killed your hernia repair, but you've probably torn a muscle at the edge there where it's healed in, where it should have been limbered up. For golfers, for a hernia repair, you can putt your first month. You can chip between week 4 and week 6, and you can start working on that full drive motion after 6 weeks, and once you're limbered up, you can start driving the ball again. So they always ask. That's where you're going to be going with your hernia repair in terms of recovery. Hopefully you understand that and be able to pick out the right time in your life so that it has minimal impact. For concrete workers, frequently that's in January and February. For people who do sedentary work, maybe have to do more with the driving involved and just having to sit all day long, and they need to get up and move around a little bit to feel comfortable. So you've got a hernia in your abdominal cavity, and it'll need to be repaired. Ventral hernias generally occur up and down the midline. The midline is a natural weak area because during fetal growth, the right and left side come together and fuse in the middle, leaving an open area at the belly button for the umbilical cord to go through. That area is more prone to stretching and breaking through so that the hernia can pop out between the muscles there in the midline. Now that's a ventral hernia. Other people have had prior surgeries in the abdomen, say an appendectomy or a laparoscopic gallbladder surgery or something where they've had their muscles pushed through, and they'll get an incisional hernia at the site of the old scar. In that case, then the scar is weakened and the guts are popping through at that site. These operations can be repaired laparoscopically or as an open operation, and the surgeon will generally make that decision based on personal experience and some assessment of how much scarring is present in the abdominal cavity from prior surgeries, whether it's an incisional hernia or even a midline hernia. So all operations have potential risks, and with abdominal surgery, one of the risks is injury to the intestines. That risk is significantly lower with a primary midline ventral hernia than it is, say, with an incisional hernia from somebody who's had a big scar gallbladder operation many years before that have a lot of intestines hanging out with a lot of internal adhesions. I've only had 2 patients in 25 years who've had injury to the intestines in the process of a hernia repair. And both of them had prior operations with extensive adhesions. So it's my practice sometimes to just start out with an open operation rather than a laparoscopic operation. Other times I will start out with a laparoscopic and then decide to convert to an open operation in order to work around a number of adhesions. The laparoscopic operations allow a better visualization of the abdominal cavity. Sometimes more hernias are seen than what you'd expect, or even other things that you don't expect, like cirrhosis of the liver or tumors, ovarian tumors and things like that. So there's some advantage to seeing more, but in terms of fixing what needs to be fixed, an open operation and a laparoscopic operation are very similar in terms of outcome. But particularly with incisional hernias, the operations are generally longer, involve more takedown of adhesions, and many times involve larger holes than what we would normally have with a ventral hernia. So that ties in with recurrence. The bigger the hernia, the greater the chance that the hernia repair is going to break down. So we want a 15-pound lifting restriction for the first 4 weeks. Then another 2 weeks, nothing over 50 pounds, till a total of 6 weeks of restriction. And this is why. Once the hernia is repaired, we're going to usually involve mesh in that repair to make it stronger than it was before, just like adding rebar to concrete makes the concrete much stronger. Same process. In order to get over the operation, you'll also have to deal with the post-operative pain. Pain in the midline is really common. Most people are on pain pills 2 or 3 days and then wean themselves off. We want you to avoid constipation during that time frame, but it's normal for the pain to go away and to get back into activities with minimal increase in pain and only temporarily. But there are some nerves of the abdominal wall that can get tied up in the scarring process, particularly where stitches go through the mesh and hold the mesh to the muscle. And it can happen even if you don't have mesh, just because the stitches are there holding things together. And if there's a nerve that's tethered down, you will end up with pain that doesn't go away, pain that can become chronic. And I've had 13 patients in the last 25 years who've had enough pain that we've had to intervene and get over that pain. And when it's a severe pain that you can say it's right here, when I turn this way, I get this electric shock, that's a nerve entrapped, and pain pills are not going to do a good job, injections aren't going to do a good job, and physical therapy is going to aggravate it. So the cure for that is to make a little incision and take that stitch out. It is not to remove the mesh, as many attorneys will make you think that all source of all problems is the mesh. But the mesh is rarely a problem, and in terms of pain, it's typically tethering of a nerve adjacent to the mesh that's the problem, and taking the stitch out will generally solve that problem. I've had 13 patients with that problem. They've all gotten over their pain, and 6 of them had no pain initially and developed their pain 6, 8, 10 years later in the process of gaining another 40 pounds. And now everything's stretching a lot differently and making it a lot more difficult for them to deal with the space issues in their belly, and the mesh is not increasing in size, and their muscles are stretching, and the nerves are getting pinched. And they get better, but in terms of minimizing the potential for pain, minimizing potential for recurrence of the hernia, any abdominal surgeries, the long-term goal is weight loss, taking the pressure off of the abdominal wall, because the hernia is a reflection of the balloon bursting, and the abdominal pressure being higher than the strength of your own tissues. And we can repair that, but you don't want a hernia bursting out elsewhere. So those are things to be thinking about specifically in relation to ventral incisional hernias in terms of risk. So thanks for listening to this information on the hernia, and hope you can find a time in your life when you can get this taken care of and avoid the emergency complications that can be problems too. Okay, now I've got a really unpopular subject, and that is complications after surgery. All surgeries have potential complications. Some surgeries have different complications from others, but there are some that need to be watched out with every operation. One of those are things that people naturally are afraid of, and that's bleeding. For most operations, the risk of bleeding is relatively low, amounts to bruising, and rarely results in transfusion. If you have religious objections to blood products, be sure and let your surgeon know about that. But rarely do we need to proceed on with any bleeding, transfusion sort of issues in general surgery and the stuff that I'm generally doing. But there are a few things that can increase your risk of bleeding that you need to be aware of. Aspirin increases bleeding, it increases bruising substantially, and unless your doctor feels like you need to be on aspirin despite the fact that you're having surgery, most patients will be taken off of aspirin. Likewise, ibuprofen, Aleve, any of the non-steroidal anti-inflammatories also have the same effect on clotting. So we'll generally have people off of those medications for a few days before surgery. External bleeding is very obvious. If you've got a spot of blood this big on your dressing, it's probably going to stop on its own. If your dressing, however, is soaked and looks like it's continuing, you need to notify your surgeon right away. Frequently, that will get better just by applying pressure. But if it doesn't, it will need to be addressed during a close time frame there. Don't be polite to your surgeon. I like that if you are, but don't wait till morning if you've been bleeding all night. That can be a real problem. And let the surgeon know if you're soaking your dressings. The other way that you know you have bleeding is something you might not think of up front. For most operations, we want you up and around the house the night of surgery. And walking is good. It prevents blood clots. It keeps you mobile. But it also gives us an early warning sign. If you're attempting to walk the night of surgery and you're pale and you're passing out, that's either a heart problem or that's internal bleeding. That's an automatic trip to the emergency room, and nobody should talk you into going to bed because you're dehydrated, you just need to rest. If you're pale and passing out, or just passing out period, when you try and walk, that's internal bleeding and needs to be evaluated that night. Call 911, call me on the way. Infections are also a risk with surgery, and anytime the intestines are cut across, there's a higher risk of infection. Wound infections are not common at Meridian Surgery Center. The risk is about 1%. If your wound is red and angry, if it's draining pussy stuff, if you're having a fever over 101, those infection symptoms are generally going to occur in the first week to 3 weeks after surgery. It's a nuisance. It might scare you, but it's probably not an emergency that requires an emergency room visit. And if you go to the emergency room, you're going to be there 10 hours. Calling the surgeon, texting a picture is the better way to do it, way faster, way cheaper, and will save you a lot of trouble. I had a patient 2 years ago who was pacing in the emergency room with this problem. He'd been there 4.5 hours, was getting really mad. Other people were going ahead of him. He wasn't getting any attention. And he just went, I'm supposed to be calling Dr. Wright. What am I doing here? And we had it all figured out for him within 15 minutes. So be aware, the emergency room isn't generally the place for that kind of a problem. Let's get it taken care of. Anesthesia-wise, your operation generally involves anesthesia. Local anesthetic has very minimal risks, but if you're allergic to lidocaine or bupivacaine in the dental office, we need to know that because that's what we're generally using, something related to that. General anesthetic and sedation procedures have risk of anesthesia as well. We're generally evaluating that in the clinic as we go along with the surgery evaluation, and patients with high risk are generally done in the hospital setting. Patients with intermediate risks and low risks are in this outpatient setting. But that's part of why we're doing blood tests and EKGs in evaluation before surgery. And sometimes you'll be set up for an outpatient surgery, and those tests will either cancel the surgery and require a cardiac evaluation, or change the setting of the surgery, or tell us something else needs to be done before the operation is done. But we deal with, in the outpatient setting, minimizing the anesthetic risk and getting you through the operation as smooth as possible. You'll be speaking with the anesthesia provider specifically about your situation the day of surgery before you go in for surgery. If you have sleep apnea at baseline, we do ask you to bring in your CPAP mask because that can be helpful in the recovery phase when you're not breathing so well and when you're not as awake, sort of like it helps you at night. Medications that we give after surgery can have reactions too, particularly if you've never seen them before. If you've had problems with certain pain pills before, we need to know that up front so that we don't get you into the same trouble that you had before. But generally, narcotic pain medications are constipating. And the number one distress call I get is usually 4 days after surgery. Somebody hasn't thought about how their bowels are working. They've had their surgery, they're doing okay, but now they can't poop. And it can be the most miserable part of your operation if you're bloated after an abdominal surgery and you can't poop and you have to push it out, and nobody wants to give you an enema. So you need to be proactive on that. So the night of surgery, drink plenty of liquids. When you're starting to eat, don't jump into meat and potatoes. Instead, fruit and vegetables. You want lots of fiber in your diet that will help you with your bowels in that immediate post-operative period. And if you're a constipated person in the first place, clean out before surgery, take laxatives, and keep your bowels working. You would rather have the trots in 2 days than bricks in 4. But certainly keep an eye on it. If you normally have really good bowels, you don't even have to think about it, be thinking about it. If you haven't had a bowel movement in 2 days, you need to take a laxative and get things going and make sure that you don't get bound up. That's the best way to have a smooth operation after the operation. So when it comes to complications, nobody can tell you all the possible complications. There are a number of things that can go wrong. Your informed consent forms will give you a lot of answers there. But generally speaking, the more experienced your surgeon is, the less complications you're going to have because they've seen things before, and that experience helps them keep their patients safe. So at Meridian Surgery Center, you'll see a lot of experienced surgeons and providers at your bedside, guiding you through your operation to minimize your potential for infection.